All right. Well, I think I'm going to go ahead and get started. It looks like we're starting to plateau on the participants coming in. So we'll kick off right now and say hello to everyone and welcome to our annual underwriting seminar webinar. As you can tell, we are doing something a little bit different this year with having a webinar instead of our traditional in-person meeting at our office at one of the hotels nearby. This is because after polling our past attendees, it was decided that we will be moving the in-person seminar to the first quarter of the year instead of the year end, as work schedules, industry conferences, and family events have made it harder to get together in the fall season. And for some reason, underwriters are more busy at the end of the year for whatever reason, whoever thought that. So I guess that makes more sense that we're actually going to do it in the first quarter. So rest assured, we will continue our in-person seminar that everybody loves starting on March 10th through the 12th of 2024. So please look forward to more information on that coming soon from our communications team. With that being said, we still have a wonderful lineup today with amazing speakers and presentations. On the agenda for today, we will be starting with Dr. Greene on mood disorders, followed by Anastasia Jaegerman and Jill Thompson on psychedelics. And finally, rounding out our series will be Dr. Joannides on underwriting thyroid nodules. And there will also be a 10-minute break in between each presenter. So for anybody who wants to go get a snack or use the restroom, and while we get the other presenters set up for the next slideshow. But before we get into the best part of the show, we would like to go over a few housekeeping items today for today's broadcast, as well as future items that will be coming down the pipeline that we're really excited to tell you guys about. As you all know, we've been conducting a webinar series over the last few years, covering a wide range of topics from claims adjudication and fraud to innovations in medicine and technological advancements and how they affect the underwriting process, and actuarial research and predictive modeling, which has been something very near and dear to our R&D team here at the Dallas office. We're excited to announce that we'll be continuing this series into 2024 and trying to double down and add even more quality presentations. So if anybody in this call today has any ideas of things they want to hear about, please let us know after the webinar, and we'll try to add that to our list as we're planning for the 2024 year. We're also excited about a future vodcast that we are putting together, so stay tuned for that. The idea is we're going to have kind of a face-to-face video recording live with Anastasia and various individuals within the industry and maybe even outside the industry to talk about certain things that we're passionate about and that we're working on from an underwriting perspective. So more to come on that. And I'm particularly really excited about that because I'm going to be one of the executive producers for that. So stay tuned. As for the webinar today regarding questions, everyone is on mute. So we ask that you please put all your questions in the Q&A box at the bottom of your screen, not in the chat. Just try to do the Q&A if you can. I know sometimes people get that mixed up. And for our first speaker with Dr. Greene, any questions that go in the Q&A, I will try to find a good spot in between his slides to ask the question so we can answer them directly during the presentation. And then he's going to have some case studies that he may answer directly, or I may ask the question as well, just depending on how the flow works. Our other speakers have asked that we hold the questions until the end, which I'll recover after we come back from the breaks. But for the first presentation, I will be trying to ask them during. Lastly, there will be a survey that will be sent out after the webinar is over. So please fill this out, as this helps us become better speakers, have better quality content for you guys, or any things that you guys are looking forward to, even in the face-to-face person meeting that we're going to be having in March. We'd like to know that. And then also, if you have any questions after the webinar, you can email us at info@optimumre.com. We have several people that check that mailbox, and we'll get together and make sure we answer any questions you have there. So now for the best part, I am honored and truly honored, actually, and excited to introduce one of our favorite and dearest colleagues and coveted speakers, Dr. John Greene. Though he doesn't need an introduction, because I know everybody knows him, he's a staple in the industry. But Dr. John Greene is Vice President and Chief Medical Director for the Underwriting and New Business Department at Lincoln Financial. He transitioned out of an academic clinical medical career at Michigan State University into the field of insurance medicine in 2001. He began his insurance career with Equitable AXA in 2001 and joined Jefferson Pilot, now Lincoln Financial Group, in 2003. While at MSU, he served as the predoctoral curriculum director, family medicine residency director, co-director of the Michigan Research Network, and director of the Primary Medicine Initiative program. He received numerous classroom and clinical teaching awards and received the college's Guiding Principles Award for Curricular Innovation, which is another reason why he's such a great presenter here. Additionally, John participated in the Training Clinical Researchers in Community Settings Fellowship and completed fellowship training in epidemiology. John is a regular presenter at industry, medical, and underwriting educational conferences. And today he will be speaking on mood disorders. The worst kind of sad is not being able to explain why. And is that not the truth? So kick it off, John, and we're excited to be here.
Thank you, TJ. I appreciate it very much. And I'm thrilled to be here as always. Truly one of my absolute favorite groups to be with and spend time with. So I'm looking forward to this afternoon. We'll see how it goes with the question. My preference is engagement, interaction, so we'll give it a shot. TJ said, the worst kind of sad is not being able to explain why. So hopefully you haven't experienced this yourself, but most of us have in one way or another, either ourselves going through this or friends, family, loved ones going through this. The odd thing about mood disorders is there's a component to it that's not logical. You can look from a logical perspective and see all the positives in your life, but nonetheless, sometimes mood disorders has the strength to really disrupt our lives. So, me, I like to start with a story. So, I was at Michigan State, as TJ went over, prior to joining insurance medicine. So I'm in the residency clinic, and we had residents, interns, students there. And an individual, female in her early 50s, was in the clinic, well known to the clinic. And generally the students or interns or residents would start, and then they would present the case to the attendings, myself, and then we would go over kind of a plan. So this woman had a long-term history of depression, major depression with recurrences. She had a psychiatrist, so we were just playing a role in her care. And one of the students and one of the residents came out, presented the case, and actually they were optimistic. The resident said that the woman, this is the happiest they'd ever seen her. And she had made some changes in her life to the positive, and was actually contemplating coming off her medications, which she had been on for a number of years. And she shared a couple things. One being, she had a significant other through many years, and they had decided to split. And our patient felt that this was a positive. And the other thing is she had one child, and the child was in the area, a grown child, and they had had difficult times through the years, and they had made a decision not to interact with each other. And again, our patient felt that this was a positive and was optimistic, related to the future. And so the question is this a good thing? What she's sharing with us, at face value, it sounds like she's happier than she's ever been. She's contemplating coming off medications, or is this a red flag? And as it turned out, it was a red flag to me, and I went in and talked, to the individual. Just didn't really make sense. Two people that were extremely important in her life were now out of her life, and she saw this as positive. Long story short, we talked to her psychiatrist. She went to see her psychiatrist, but sadly, about 2 months later, she took her own life. So on a lighter note, you can see that on this slide, I kept trying to convince my therapist that I don't hear voices in my head. Eventually, she pointed out to me, sadly, I don't have a therapist. So we're going to launch right into it. These are actual cases that we saw as part of life insurance that, as part of individuals that were applying for life insurance. So these are things you see frequently. So the first is a 35-year-old male who was diagnosed with depression 15 months ago. He's currently on Remeron after an initial treatment with Luvox. The client admitted that he missed 2 weeks of work at the time of diagnosis, but he's been back to work since. We had medical claims, so health claims data on the client, and there's diagnostic codes for recurrent major depression. Prescription records demonstrated that he's used Zoloft and Wellbutrin in the past. So we're going to try, to chat in. So I'm giving you limited information, but what do you think about the risk initially? And then when you think about that, what other questions, what information didn't I give you that might be helpful in assessing this risk? So TJ, just let me know if things aren't coming in, I'll just start to talk.
Yeah, there was one question, any changes in dose?
Yeah, it's a great question. So we're always looking at what dose an individual is on, if they're on the lower or higher end, and if there's been any changes. And there has not been any changes. So the Remeron dose has been stable.
And then what are his current symptoms?
Yeah,
There's
so
actually quite a few coming in.
what's that? Oh, now there are a bunch coming in. So from a symptomatic perspective, this individual has been actually relatively asymptomatic for about 6 months. So doing very well. So then it gets to that, how long, do we typically treat, or will we see an individual that's being treated? TJ, is this going to be too much? I see.
No, it's fine. So any changes in family situation or work, and how long did he stay on each RX?
Yeah. So home environments is favorable. He's got a strong social support as it relates to his home environment. So great question, which was never disrupted, perhaps other than that first 2 weeks. What was the second part of that, TJ?
Yeah, it said if there, how long was he on each RX?
Oh yeah. Great question. So he was on the Luvox for about 4 weeks, and he's been on the Remeron since. And there was there was a small period of time where they tapered one on, tapered one off.
Okay. And then what happened 15 months ago that caused the initial DX?
Yeah. So this is the illogical part, right? Nothing that he could put his finger on. So there's nothing situational in his life that changed that actually caused the depression.
Okay. And then any hospitalization, any history of suicide ideation and suicide attempts? And is he managed by a psychiatrist or primary care?
Yeah, all great questions. And so there was no suicidal ideation. He's never attempted suicide in the past. He's never been hospitalized, but a great question. And TJ, what was that? There was a third, forgive me.
Yeah. So going back through these, any suicide attempts or ideas on that? That was kind of like the last part of it, I believe. And the rest of these questions are kind of the same that are coming in.
Okay. So, great questions. And they're questions to me that, we should be asking for every client, that we're seeing as it relates to it. So one thing, if it was asked, so substance abuse is another thing, that I always like, self-medication around alcohol or other drugs, come to bear as it relates to this. What about the medications that he's currently on or he's been on in the past? Any red flags around that? And why do you think we went from, or they went from Luvox to Remeron? And does that cause you any concern?
Some comments are saying Luvox is unusual, psych side effects. typically used for OCD.
Yeah, so it's not a common one. So I agree that it throws a little bit of a flag. Now, he took it for 4 weeks and then stopped. So I suspect that was due to inadequate response, and they changed to Remeron. And Remeron is what we kind of classify as an atypical antidepressant. Generally, it's not a first line, unless an individual's had side effects with the typical first line antidepressants in the past. And so they opted to go to Remeron here. In this instance, we know that that wasn't the case. He was treated with Zoloft and Wellbutrin in the past. Now, Wellbutrin is another one that tends not to be a first-line drug, although we occasionally will see it. So it falls into that atypical group. So with those drugs, the other thing I would want to know is how long was he treated with the Zoloft and the Wellbutrin in the past, and when that occurred. So it turns out that he's been treated. Zoloft was first. He took it for about 4 months, and that was about 5 years ago. 2 years ago, he was put on Wellbutrin, and he took that for almost a year. But again, single medication both times, and now we're looking. Now we have 2 medications, but constant dose of Remeron. We're looking at treatment over a year.
Okay, yeah, there's quite a few more coming in here. So when was the other episode?
Yeah, so those were, so one was about 5 years ago, one was about 2 years ago. So, great question. And so this would be the third.
Okay. And then, but why family MD would prescribe Luvox in the first place? Why not try to more common RX prescribed?
It's a great question. We had the same question. Can't answer it. It's not one we typically see. It is an SSRI, but it's not one. We didn't see anything in the records that really supported why Luvox. But it's the question you should be asking.
And then 2 kind of questions that haven't been asked yet is family history or psychosis or mental disorder and 2 weeks off work is concerning. Any additional time off?
Yeah. So there was no other. I mean, there was a familial history of depression, but that's all we knew. Didn't know exactly who it was or the severity of it. And 2 weeks off work is concerning. I mean, typically when I look at that, it's going to bump it from a mild to a moderate at minimum as it relates to it. It gives you an idea of the degree of symptoms at time of diagnosis. Now, fortunately, in this instance, we have some time under our belt, and again, doing well on a constant dose of the Remeron. And the other thing is, this wasn't a first episode, based on both the claims data and medication use.
And then last, how long was the job that he was at his job?
Oh, yeah, don't know, but have no reason to think there was any change in job of recent. There was no mention as it relates to that. Good question. I mean, anything that's disruptive to life, changing as it relates to that, the financial situation, changes at home, there was nothing that we could find as it related to this individual. Now he's 35 years old, so fairly young.
Perfect. There's no other questions on the
All right. What if, so I put on here, what if the client was on a combination? It doesn't have to be Luvox, but an SSRI and Abilify. When we're looking at this risk, do you think this is a major depressive episode? Or do you think it's a minor depressive episode? Do you truly think this person has recurrent major depression? Because we have to decide that as it relates to how we see the risk.
Yeah, suggests more severe if also on SGA, and major based on time off work and meds taken.
Yeah, so I agree. So I think this is a bit more concerning. I mean, there's some favorables here that we've talked about, but this to me would be at least a moderate depression, based on the history. Tough to tell. Zoloft use and Wellbutrin in the past, relatively common medications. We're looking at 5 years, 2 years, and now duration of treatment. Zoloft, remember, was about 4 months, while Wellbutrin was about a year. Not uncommon, with a second episode or a third, that you will treat a bit longer. And sometimes, of course, some of these individuals end up on maintenance therapy. So they end up on a lower dose single drug.
Yeah, and Dr. Greene, would you suspect Abilify may being used as a booster to enhance the effect of the other meds would need to know the dose, assuming?
Yeah, I think so that we'll look at this next slide because it's a perfect kind of transition over. So medications provide a lot of help in regards to not just a current episode of mood disorder, but past episodes of mood disorders. And those all play into kind of our overall risk assessment. So when I look at the medications, I look as closely at past medications as I do current medications. This group, astute group, picked up, changes in medications, not just what medication somebody's on, what dose they're on, is the dosage changing over time. So in the left column, the selective serotonin reuptake inhibitors are probably the most common, and they're the most common that we see. The serotonin norepinephrine reuptake inhibitors, so Cymbalta and Effexor, would be number 2. So those are the ones we are most likely to see. The serotonin modulators, the Wellbutrins, the Remerons, those that fall into what I consider more atypical are generally not first line. So they're either telling you that they had perhaps a treatment failure on a first line agent, or they had a side effect related to a first line agent. So again, helpful information. I put tricyclics here. We tend not to see use of tricyclics much anymore. But when I started to practice, we used tricyclics all the time, very common. The monoamine oxidase inhibitors are rare to see use. They have a higher risk profile for various reasons. So they throw a bit of a flag if we do see them, although it's quite rare that we do. And then kind of the question getting at the Abilify, I look at these, what is classified as augmenting therapies. So they're going to a combination or an atypical type medication for individuals that tend to be more resistant, or it could be more severe, or it could be a combination of both. So if I see an augmenting therapy like second generation antipsychotic, or what they call atypical antipsychotics, so Abilify falls into that bucket. Anticonvulsants are another one. We will see their use, with depression. Again, it's not going to be for a mild depression, so it throws a bit of a flag to me. Lithium is another one. We will see it used for depression alone, but again, typically more resistant depression or more severe depression. Also, you can see a combination of agents. So a second antidepressant from a different class is considered augmenting therapy. Thyroid hormones, specifically T3, we see it. It's very rare that we see it, but it is considered an augmenting therapy. Psychotherapy, to me, is more than augmenting, because it's not uncommon that psychotherapy will start initially with a depression. So in and of itself, it's often used in combination, with an antidepressant medications. So, and in fact, most people do better to have it, to be getting both psychotherapy and pharmacologic therapy.
Dr. Greene, is there any
Yep.
concern about non-psych issues with Abilify that can cause weight gain from its use?
Yeah, I think there's a small risk as it relates to that. To me, any medication, if you're going to opt for an atypical antipsychotic, for a mood disorder, mental health history, like anything, you weigh the plus minus as it relates to potential side effect. So if somebody if you're concerned enough about well-being around mood disorder, to me, that would outweigh any concern in regards to a weight increase. But it always is something. It's something that I would talk about if I was prescribing it, to my patient, just to make sure that they're aware.
Perfect.
All right, let's talk a little bit about major depressive disorder. So this is something we see all the time. 10% prevalence of major depression within the year. If you look at lifetime, it generally falls somewhere between 20 and 30%. So most of us have been touched, by major depression somehow, some way in our lives. And the other thing is recurrent. So if you've had a major depressive episode, you have a 40% chance of a recurrence within the next 2 years. If you've had 2 episodes, then your likelihood of recurrence within the next few years is about 75%. So it's not uncommon that if we see major depression, that we see more than a single event. It's 2 times more prevalent in women over men. The average age of onset is a little bit lower than people think. It's probably closer to 30, but 30 to 35. About 60% of individuals respond well to the initial treatment. So we tend to see, if it's a first event, 60% of the time, often they're going to be treated with one medication. That's not going to be changed throughout the course of the depression. So we need to make sure that we pick out individuals that are at higher risk as it relates to that. So treatment-resistant depression is defined as individuals that don't respond to 2 trials of antidepressants. So it's about 30% of the depressed population. So this is a higher risk group. They're also higher risk for recurrence down the road, when we're looking at that from an underwriting perspective. We talked about the augmenting therapies, that you want to pick up on this. And again, whether it's today or if it was 2 years ago or 4 years ago, it comes into the way I look at risk. The duration of therapy is generally, now this can vary, but it's generally about 4 to 6 months with a first event after the symptoms resolve. Now, our client, the one we talked about, 35 years old, 15 months out, they're still being treated, not a surprise. So, somebody asked the question very quickly, that what were symptoms doing over time? So this individual had been stable for at least 6 months and had done well even the prior 6 months to that. So favorable as it relates to that. Maintenance therapy is recommended for certain circumstances. So the only reason I bring this up is if we ended up with the client we just talked about on maintenance therapy, it would be a little bit different. There's a lot of people out there that we see that are on one drug and have been on one drug for multiple years, often same dose of drugs. So often it's an SSRI, and they've been on it for 5, 8 years, kind of a scenario. Now, those individuals, I think more often than not, either have a minor depression kind of ongoing, so more of a dysthymic. So dysthymia is a low-grade depression. By definition, that's there for greater than 2 years. Because a lot of these folks end up on a low-dose SSRI. Sometimes they try to wean it. Not uncommonly, the person says, I think I'm feeling worse again. And so the provider just goes back to the dose that they were on. So I think we see a lot of those individuals. And the risk around those individuals, as we'll see, is actually quite low. So let's look at depression based on gender and age. So we talked about the fact that it's more common in women than men. This just gives a breakdown of the ages, of diagnosis. No big surprises here. We talked about the majority, the kind of the prime ages 30 to 35, but you can see even ages 40 to 59, we see a lot of underlying depression. So what's the risk around these individuals? Well, we know that the risk increases with the severity of depression. So we need to get it right. Is this a minor? Is it a mild? Is it moderate? Is it severe? And then the risk persists in older ages, doesn't really change. So it really gets back to the degree of underlying depression. So the data on minor depression is mixed, but it actually demonstrates very limited risk. And so if we look at all in, these are individuals on the far left that don't have a history of depression, so the relative risk. So we're comparing people with depression to those without it. We bucket the mild and moderate together, and you can see that the relative risk is about 2 tables, at most for those individuals. And even moderate to severe, we're only getting up in the table 4 range. Now there's buckets of risk, within that that are higher. So this is all in. The good news here for us is we can insure these individuals, and the risk is relatively small. If we're pretty good about discerning, hey, is this moderate or better? And can we identify the more severe individuals? If the answer is yes, then we're going to do our job, and we're going to not only provide coverage for our clients, but protect the bottom line for our company.
Dr. Greene, there's actually a question that just came in on studies for Seroquel. Um, uh, there's been some conversation, I guess, with some psychiatrists about the long-term use of it and not being ideal at the time a few years back, and wanted to know, because they didn't know the long-term effect on the nervous system. Would it be something that underwriters need to look at more carefully when someone is on this medication? And do we have more favorable studies now that would show us this?
Yeah, and I assume the question relates to Seroquel use for depression, but TJ, I'll take it. I mean, I think that, I mean, regardless of the underlying cause, I mean, one, I would be more concerned about the risk for the individual, and for us, for that matter, for an individual that is on long-term Seroquel. I do think, the studies have shown some risk, to the individual that's on a long-term treatment. More recent studies have actually looked a little more favorably, upon that risk. The good news is we don't see a lot that fall into that bucket that would be on long-term Seroquel use. But great question. So we've all seen these, not often, but we're seeing them a bit more frequently. So I wanted to bring it up. So brain stimulation therapies. Now these are typically used for individuals with more severe and or resistant depression. So electroconvulsive therapy, we've seen deep brain stimulation, transcranial magnetic stimulation, vagus nerve, and then transcranial direct current stimulation. My take home for these, of course, we look at the situation and all the details we have as it relates to it. But generally, this is not a first line, treatment. And so we don't expect to see its use for milder depressions, and we're more likely to see it for severe depression or for resistant depression, depression that's not responded, to other treatment modalities. And so is it possible that you could have moderate depression that would end up being treated this way? And the answer is yes. And there's been some movement even for milder forms of depression that are more chronic to give it a try. So we have to keep our minds open as it relates to this. But to me, currently, if I see it, a bit of a flag goes up, again, either for more severe or more resistant depression. So if I was looking at a client, we know that historically, if we're going after psych records, if they see psychiatrists, what we get back is generally a one-pager or two-pager that kind of summates the history. And in fact, we'll have a case that we use an example of that. It doesn't give us a lot of particularly useful information when it comes to assessing risk. We've picked up more on the brain stimulation therapies with health claims data, because those get billed. And so we found more clients. Now, when I see that, I'm going to want additional information to better assess risk. So again, we don't want to miss the big things. We want to be able to determine when somebody has a higher risk, more severe or resistant depression. So what are the red flags? And I know this group knows them because they went through, the red flags when they were when you were questioning that first case. So
Well, Dr. Greene, there's actually one question before you get into the red flags of that. Would only a psychiatrist be able to do this type of treatment with a neurologist?
Yeah, generally the answer is yes. I mean, you would rarely see it from a non-psychiatrist. Is it possible? The answer is yes. But for the most part, if you see it, I think it's fair to assume that it's a psychiatrist that has taken responsibility for the care of the client. So red flags with depression, the prior suicide attempt is big. Suicidal ideation, especially with an intent and a plan, carries a significant risk. It's rare that we have a definitive plan, and sometimes that doesn't get documented. And so our ability to know that, it's not going to be great. But it's not uncommon for a person that's depressed to think, I don't want to continue to live like this. If they don't have a plan or really thought through as it relates to it, in and of itself, to have a thought around that is not overly concerning. I'm not saying it doesn't carry any risk, but it's something that we see fairly commonly. I really look to see if there's anything that they talked about regarding, did you actually take it to the next step? Have you thought about how you might do that? And if somebody has, the risk has gone up fairly significantly. And if you think about suicide, that for every suicide, there's about 20 to 30 attempts at suicide. So a lot of folks attempt suicide, which, again, carries significant risk going forward. So it's something I'm always looking for. Substance abuse history, we have a separate slide on this, but the risk related, especially if it's been recent or current substance abuse, significantly increases risk around mood disorders and mental health issues. A history of psychosis or catatonia, again, we may not know that, but it raises the flag in regards to severity. We tend to see those more with severe depressions. We talked about the brain stimulation therapies, and then medications we've already talked about. The MAO inhibitors and the mood stabilizers raise a flag.
Dr. Greene, what about the use of other types of treatment, such as low-dose ketamine therapy to treat depression? There's a lot being heard now about it being an alternative therapy for treatment to resistant depression, and I was curious if you could comment on that.
Yeah, so we actually have a case on that. So I'm going to hold my comments until that. It's a great question. We are seeing more of that, so we'll talk about it in a second. So this slide, I think there's three messages to take away from here. One is a simple one. If you look at schizophrenia, no surprise, versus bipolar versus unipolar depression, the risk is highest in schizophrenia, bipolar second, depression is third. The second is women carry a bit more risk, with the underlying diagnosis than do men. And thirdly, if you layer on substance abuse disorder to an underlying mental health disorder, risk goes up significantly. So this would be more a recent or current substance abuse disorder history, but it's something we certainly don't want to miss, and definitely changes the complexion of the risk going forward. So let's move on to case 2, a very common scenario that we see in life insurance. 50-year-old female, history of I'm sorry, I was thinking about another case. So this gets back to the ketamine. So this is a 50-year-old female with history of recurrent major depression, admits to the history. She was hospitalized twice in the past, most recently 3 years ago. 3 weeks ago, she completed treatment with intravenous ketamine, having received infusions twice weekly for 4 weeks with a favorable response. Currently, she's on Abilify and Celexa. So question was already asked. So I mean, if anybody wants to take a crack at this in regards to how do you see the risk based on, again, limited information that I provided. Anyone? Are there any takers with this case? What do you think?
Comment here, unipolar, bipolar,
So,
and then DCL.
So was that a question? So this is unipolar depression. Was that?
Yeah, I think it was just a comment they were making.
Okay.
I guess question you.
Thanks, TJ. What do you think about the risk? So I agree. So you could question the diagnosis, and I think that's what the individual was doing. I think this person truly has recurrent unipolar major depression, no evidence of bipolar. Um, hospitalized twice in the past. 3 years ago was the last time. 3 years ago is not so bad. I mean, when we look at timing as it relates to that, who are they going to treat with ketamine? Are they
Yeah.
going to
So
treat? Yeah.
so there's a lot of comments here about it being considered maybe moderate to severe major recurrent depression. I'm seeing a lot of that. And then some questions about if there's any substance history uh, going on with this case.
Yeah, great question. If there was substance history here, it certainly would change the complexion of the risk, wouldn't it? So there's nothing. There's nothing as it relates to substance history. Yeah, I would agree. I mean, when you're looking as a rule, for ketamine currently, now this will change, I think, over time, and it's already moving a little bit in that direction. But generally, ketamine is reserved for individuals that have failed, other treatments. And historically, when it first started to be used, it was generally used for people that failed ECT. So these were individuals that had severe depression and had failed other therapies. So I think you're right to think that the degree of depression here is likely severe and it would go along with the past history of hospitalizations twice in the past. And they're currently on Abilify and Celexa. In and of itself, I mean, they're on two meds, one being Abilify again. So raises a little bit of a flag there. What else about this case concerns you? So to me, it's the timing. So it's always nice, especially when you have a severe depression, to have some time under your belt in regards to see how somebody does over time with treatment. So this individual just stopped use of the ketamine 3 weeks ago. Any idea how long ketamine tends to work?
Comments here saying not long.
That's absolutely, I think that's exactly how you should be looking at it. Problem is length is duration. The response is quick, which is nice. But the duration of response tends not to be that long. So a scenario like this, we didn't offer on this case, and but we said we would relook at it. The issue was the timing. So again, this client looks to have recurrent, major, severe depression, 2 hospitalizations, a recent treatment with ketamine. So we really didn't have time under our belt to see how this person was going to do longer term. Any other thoughts on this case?
Yeah, and there was another comment about it typically needs boosters within a year.
Yeah.
Well.
Yeah. So that's the one thing when you have a new treatment modality like ketamine, the question is, one, how long should you treat upfront? And do you need to come back? As the comment is suggesting, how frequently do you need to do that? What's the best way to dose it? Because you can give ketamine numerous ways. And how do people do longer term after use of ketamine, which we don't have a lot of information currently. So as we talked about, it's often used for severe treatment-resistant depression without psychotic features who failed ECT. A single infusion of ketamine, which is, I find pretty amazing, although if you've ever had ketamine, I think you might have some idea why. It produces a rapid onset response. So about 50% of people feel better quickly after that initial dose of ketamine. But the duration is only a couple weeks. A little bit different, again, as we look at different protocols in regards to how it's administered. You can see it can be given in the most common way is IV. but you can give it intramuscularly, intranasally, orally, or sublingual. And then dosage, and then how long do you treat? One thing that concerns me a bit, so you'd want records on somebody like this, is it's increasingly available, freestanding clinics, outpatient clinics. And I'm not thrilled. I mean, to have anesthesiologists there is a must. I'm okay with that. But ideally, you would like to see a psychiatrist involved as it relates to treatment. What we're seeing in some of these clinics is they're not involved. And so that's a bit more problematic, from the standpoint of assessing risk for us. So of course, we would need additional records on a scenario like that. So the benefits and safety of ketamine treatment are currently not known. I mean, we know that you get a therapeutic response. We know you get that quickly. We're not quite sure how long that lasts. So time will tell. But this is something I think we'll get very versed at in the next couple of years, because we'll see a fair amount of it.
Doctor, what about other complications with ketamine, in particular with causes of high blood pressure and increased heart rate?
Yeah, it's a risk. I mean, the nice thing, I mean, since individuals are being monitored, at least currently, as it relates to ketamine, so it's the benefit of having an anesthesiologist there, because they can counter, those type side effects that do occur, with ketamine use. So as long as they're in a monitored situation, that risk is minimal.
And is there any addiction risk with ketamine?
Well, it wouldn't carry necessarily the kind of typical addictive issues we would expect with some other drugs, but yes, there is some risk. I mean, ketamine's tough to get your hands on, for one thing, so that's a good thing. So generally, you're only going to get treatment as it relates to being supervised in a scenario watched, but there is some risk as it relates to that. I'd be more concerned about the other risk factor in regards to blood pressure issues and certain other issues that are more acute side effects as it relates to the ketamine.
Yeah, and there's another question that's kind of interesting because it might carry over into our next presentation. But wanted to know your view on ketamine use differing from the emergence of microdosing with psychotropic, psychotics and psilocybin that's gaining traction in other countries with some success.
Yeah, so I mean, I think the jury's out as it relates to it. I'll let Anastasia and Jill take on that kind of the aspect of the microdosing and the psychedelics. I think it's a little early to call as it relates to both the therapeutic benefits in the longer term or short term and longer term risks. But again, I think as long as you're being treated by an individual that knows what they're doing as it relates to it, you're being monitored properly, those individuals that are higher risk are identified up front, I think the risk is pretty small. So this is the one, forgive me, that I started to talk about that we see an awful lot. 42-year-old female, history of generalized anxiety disorder. She's been on Celexa for 2 years. She sees a therapist on a monthly basis, global assessment function. So the GAF score 12 months ago was 58, so that was moderate. The GAF score 1 month ago was 75. She's got a history of alcohol dependence, which of course raises a flag, but she's been sober for 7 years. So what about this one? So what do you think about this risk? First off, what's your gut feel? And then what if she didn't have a history of alcohol dependence? Does it change anything?
Getting mainly standard risk here.
All right. What about preferred risk? Any takers?
Would consider preferred if no substance, and then a few others saying no preferred.
Okay. Yeah, I think I think that's if this woman didn't have a substance history, I think preferred's in order. I don't think that's unreasonable. Any additional information? that I didn't tell you? I mean, the same type of things in regards to risk factors that we see with depression. So if there's the substance history we know about, disruption to life, disruption to work, disruption to social, relationships, and those things matter. Missed time off work as it relates to it, is important. Suicidal ideation, you can see it, with anxiety, past suicide attempts, family history, to some degree, comes into play here. This client really had nothing as it related to it. There was nothing that was disruptive of life that we could find as related to her history. What about 2 years of Celexa? Surprise you? Anybody? And kind of, is it a positive or negative as she sees a therapist monthly, do you think?
Yeah, a lot of the comments here are more of not really a surprise, but it can be frustrating because it seems like there's a lot of individuals under treatment for anxiety nowadays.
Yeah.
But yeah, that seems to be the common theme.
All right. And so what if this client, I mean, so the therapist piece to me is a positive. I don't see it as a negative. I mean, some people will. Some people say, well, they must be struggling more if they're seeing a therapist. Actually, the studies have shown that if you're getting treated both pharmacologically, especially with Celexa, stable dose, 2-year period of time, and seeing a therapist, those individuals tend to do a little bit better than individuals that are just treated with meds alone. The other thing about anxiety, a lot of the individuals we'll see, although we may not know the history, is a lot of folks with generalized anxiety disorder, even moderate, they're on no meds. They may or may not have seen a provider, so we may know nothing about it. What if this client was on Celexa and Ativan?
That's actually a comment that came up. Wonder if it would proceed with caution if you were taking that combination.
It would cause me a little bit of concern. What's the concern particular? What would be your particular concern as it relates to Ativan? Anybody? Or any benzo?
Addictive nature
Yep.
seems to be the main thing here. Respiratory and addiction. Yeah. Addiction
Yeah,
to benzo.
Yeah, so the alcohol dependence really would raise a flag, right, in regards to chronic benzo use. So I wouldn't like it. So the addictive nature, the addictive history, would definitely cause me more concern, and I think would increase this risk, of course. When this last question about what are the preferred pharmacotherapies for treatment, they're generally SSRIs, and so that those are number one. So the Celexa is kind of what we expect. So the serotonin, norepinephrine reuptake inhibitors too, they're fine. You will sometimes see benzos used short term as kind of the SSRIs, pick up steam and are more effective over time. So if you see short term benzo use initially and that's weaned off, I'm comfortable with that. That does not cause me concern. So I think we all know this, but these individuals that have general anxiety disorder, it's excessive anxiety. It's not feeling a little bit anxious as it relates to your day. So most of these folks, it will impact their life to some degree. It's more than the norm. If you look at prevalence rates, so in 2020, 9.5, 3.5, basically 2.5% of adults experienced mild, moderate, severe symptoms over the past 2 weeks. So if you think mild symptoms, 10% of the population, 2.5% in the past 2 weeks have had severe anxiety. We see it. We talked about the selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors. Those are what we like to see. Those are what we expect to see. We talked about use of benzos as kind of a bridge until the SSRIs reach a more effect. But we don't like to see them long term. I just put this in there for you. It's one thing we tend to have to look up every time. Okay, what was that GAF score? What does it mean? So the mortality around anxiety is mixed, but it's mild. So if it's just anxiety without a lot of underlying comorbid issues or comorbid psychiatric conditions, these people do well. And the risks are actually quite low. So a lot of this is comorbid. histories. And of course, substance always raises a flag around risk. And there's been numerous studies out there. Interestingly, some studies have actually shown individuals with anxiety have done better than individuals without anxiety. You can see that 0.9. So when you look at relative risk, and for the most part, we don't see that, but we see risk fairly close to 1, mildly above 1. So back to that comment about standard risk with these individuals, and some individuals with stability over time, certainly we go preferred. This is a 39-year-old male, reports a history of depression and anxiety. This is where we got the one-page psych summary. So we've all seen these. They didn't provide a diagnosis, but they said the client sees the psychiatrist on a regular basis, has for a number of years, is doing extremely well with a lot of favorable aspects of the risk, and they feel they overall have a very favorable prognosis. Current medications are lithium and Lamictal. The RX demonstrates past use of Prozac, Latuda, Zyprexa. There's a history of suicide in the client's father. So what are your initial thoughts around what the underlying diagnosis likely is here? And how do you see this risk?
Yeah, the main concern we're getting here is possible bipolar depression with family history. Yeah. How long were they stable, and moderate to severe risk?
Okay. Well, I think that's spot on. So when you see lithium and Lamictal use, the likelihood they have unipolar depression is extremely unlikely. So we actually got a claims data on this individual, and no surprise, multiple diagnoses for bipolar disorder. So when you see that lithium Lamictal, I mean, that's a very common combination used often for maintenance for individuals with bipolar disorder. The other thing, again, we talked about not just current meds, but past meds. So the Latuda, Zyprexa in the past, there's Prozac, but this in every respect looks like a bipolar. We looked at the one slide that looked at mortality around bipolar and the fact that it's higher than it is with depression. And so, yeah, I say this, agree, this looks bipolar, and I would see this risk as moderate to high substandard. So we need additional details, but just out of the gate. So what drugs are considered mood stabilizers? I mean, we hear that term. I mean, a lot of people think, well, it's lithium, isn't it? Well, lithium is one, but if we go back to those augmenting therapies, there's others on that list. Anyone?
So we're getting Seroquel, Abilify.
So the atypical, the second generation antipsychotics fall into the bucket with mood stabilizers. The Lamictal, so the anti-seizure medications, fall into the bucket of mood stabilizers. And so when you see their use, what are the most common underlying disorders that relate to use of mood stabilizers? So we know bipolar is one. What else? We talked about
schizophrenia.
Yeah, so schizoaffective disorder primarily, yeah, absolutely. That falls in the bucket. It's fairly common. Borderline personality disorder is another that we'll see mood stabilizers used for. And then, of course, we talked about the more resistant or more severe depression. So we see it. It's our job to try to figure it out. Not uncommonly, at least for us, we see this. For whatever reason, people don't admit to bipolar. Now, some do, of course, but this individual did not. And of course, the psych summary didn't provide any diagnosis. But what about this family history of suicide? Does it make a difference, really, if dad died? versus that I tried, that the client themselves tried, or that they have suicidal ideation?
Yes, there seems to be a very good big concern for the history of the suicide in father.
Yeah, absolutely. So it definitely carries risk going forward. So let's talk a little bit about bipolar. Again, individuals with bipolar, their life is disrupted. So when we talk about manic episodes or hypomanic episodes into depression, it generally affects their life. It affects their work. It affects their family. It affects their social relationships. It does impact their world. It affects males and females equally. So the mean age of onset is 20 for bipolar. So 30 to 35 is the most common for depression, much younger for bipolar. So mood, energy, activity, sleep, cognition, and then we talked about occupational and interpersonal functioning are affected. Now, we don't always have the information as it relates to that, but that's what we expect. Not uncommonly, it manifests with comorbid psychiatric disorders. So it's not uncommon to see substance abuse, to see ADHD, eating disorders, post-traumatic stress disorders, and individuals that have an underlying bipolar history. It's the 18th leading cause of years lived with disability. So if you're looking at like a long-term care rider, or if you do any type long-term care underwriting, is a real concern as it relates to it. Increased all-cause mortality. So life expectancy is decreased about 9 years for individuals with bipolar. Some much more than that, some, of course, less than that. 2 to 3-fold increase in deaths due to coronary disease, COPD, diabetes, and pneumonia. So why is that? Anybody? Why do you think it would have an impact on other underlying medical disorders?
Only comments I've gotten so far is smoking.
Yeah, so I mean, that's a good one. So it's lifestyle. They're more likely to smoke, they're more likely to drink, they're a little less likely to exercise. So a lot of it's lifestyle issues as it relates to it, but smoking's a big one. And we talked about suicide risk. So risk is higher in men to start with. A previous suicide attempt clearly carries risk, but look at the degree of risk of family history carries as it relates to suicide. So it's not a small thing, that our client's father committed suicide. The other thing is, it's not uncommon that we see individuals with bipolar that are on no medications now, which actually can be a flag. And so it's really timing, frequency of events, and often you kind of gauge, the number of manic events, when they occurred, and when was the last one. But often individuals, because it's often a recurrent pattern as it relates to that. So individuals that are on maintenance therapy actually tend to do better longer term. So just the fact that this person is being treated the way they are in and of itself is not a negative. If somebody has a manic episode, any idea of how long it takes to resolve? Kind of on average, how many would resolve in 4 weeks, 8 weeks, 16 weeks? Any idea? So it's about 25% 4 weeks, 50% 8 weeks, and about 75% 16 weeks. So the only reason I mention that, I mean, if we're looking at somebody and we're gauging kind of the degree and can we offer, or when can we offer, I kind of keep that tucked in the back of my mind in regards to what I would expect going forward. So since we raised the possibility or the consideration of suicide, I just wanted to mention a couple things. Not a big surprise that people that commit suicide have underlying mental health conditions. In 25, so 1 in 4 have a substance abuse history. So again, that substance abuse keeps showing itself in regards to risk, not only with underlying mood disorders, but for the suicide risk itself. Suicide rates have increased in nearly every state over the past 2 decades. And in many states, it's been 30, even upwards of 40% increase in suicides. And there's numerous reasons for that. In 2021, 12 million adults seriously contemplated, to the best of our ability to figure this out, suicide. 3.5 million made a plan, and 1.7 million actually attempted suicide. And we talked about attempts to actually successful suicides, 20 to 30 to 1. But it gives you an idea of kind of the degree of issue that suicide is in the U.S.
Dr. Greene, is there
Yeah.
more prevalence on suicide depending on if it's bipolar 1 versus bipolar 2? And
Yeah.
what about mental issues with transgender and non-gender?
Yeah. So two good separate questions. So there's suicide risk for bipolar 1 and 2. It's present in both. Probably a little bit higher in 1 than 2. But for the most part, I mean, we'll go over here kind of the risk as it relates to suicide. I kind of look at the risk in a similar type fashion, as it relates to that. Do they have underlying risk for suicide other than the underlying diagnosis itself? When it comes to transgender individuals, that of course the risk of underlying mood disorders is higher. The risk of suicide in this group is even higher. So yeah, it's a real concern. But again, it's something that I kind of assess suicide risks consistently, based on underlying risk. And is it important to know that prevalence is a little bit higher in some groups than the other? And the answer is yes. I mean, for the most part, if somebody hasn't attempted suicide or is not manifesting, suicidal ideation, we're not going to take an adverse action regardless as it relates to that. So hopefully that answered.
Do you have any comments on why males are more likely to complete an attempt as to females?
Yeah, we have known of this pattern for years. There's some different thoughts as to why it is, but we don't know for sure, TJ. And I don't, I'd just be speculating, which there's been a lot of speculation as it relates to it. One thing I'll tell you is that it's been fairly consistent over time. Doesn't seem to be changing. So I think we can feel fairly comfortable as it relates to kind of assessing what the risk is, male to female. So kind of to that end, women are more likely to attempt suicide. Males are much more likely, to complete a suicide. That's especially true in elderly Caucasian males. They're actually the highest risk group. Any idea why, or any thoughts why that might be?
I'm getting death of spouse, chronic illness, loss of loved one.
Yeah, so it's an interesting thing. So you're right on. And so if it's often changes in life, and the loss of a spouse, the loss of a significant other would be top of the list. Historically, it may be changing a bit, but males have been cared for more often by their partner than the alternative, than the opposite, where the male is caring for their partner. And so they're often a bit more in a situation where they feel lost, or they feel ill-prepared, or or despondent, that I've always had someone looking out for me and that person no longer is here. The other thing is, well said, that the second one is chronic underlying health conditions. So those put a risk on us, for various things. And so underlying comorbid conditions carry risk. And so if you layer that onto underlying mental health disorders, risk goes up. And then lastly, any other changes. If you were to go through a retirement, those type things, if there's financial issues as it relates to where you are in life, all those increase the risk, for elderly males. So, and those kind of are all laid out here. So we rarely see it, but when I look at an older individual that's applying for life insurance, if they have a history of underlying depression, especially a newer diagnosis, the risk is going to be higher in the short term as it relates to that. That's one that I'm a little more cautious with. So I think you touched on all of those things. I mean, historically, this group has been very knowledgeable. This year, I think even more so. So let's kind of summarize, and then we'll see if there's any last questions. So mortality risk of misclassifying a mild or moderate severity mood disorder is relatively low. So we can take a breath, with those. If you're pretty good at saying, hey, I think this is mild, the risk there is not that high as we looked at. And so you don't have to worry much. I mean, where we get into trouble, I think, is where we miss the big things. And we miss the big flags that show up. And so those are the things, if we can prevent ourselves to be knowledgeable enough to say, this is a much higher flag that's been thrown in front of us. This may be one we want to postpone for a period of time. Now, all of us, including me, want to offer. If we can offer, I'm offering. And so I'm always looking for ways, but there are times that I know better than to say, or maybe I rate high substandard in a scenario, or I postpone for a period of time. But knowing the red flags associated with depression serve you well. So the suicide attempts, substance is very big, not something you want to miss. Psychosis or catatonia, yeah, but we often don't have that. Treatment modalities in the past, so the brain stimulation therapies, the monoamine oxidase inhibitors, mood stabilizers, and again, mood stabilizers you're going to see with some folks that may have less than severe depression, but are resistant to other therapies. So in and of itself, I try to piece all that together. We talked about suicide risks. I always kind of rank order in my mind. Males are at higher risk, prior suicide attempts. Again, substance shows itself, underlying serious illness, a recent loss, social isolation, sense of hopelessness. That's often a question that's asked, on, the questionnaires around a depression. So the bottom line in regards to underlying mood disorders, the first thing I do always is I look at what we've been told in regards to the history. I look at medications because they will tell you things that that you can learn that otherwise you perhaps wouldn't know. I find health claims data. I don't know if this group has had much experience with those, but when it comes to psych history, it's very helpful information. One, you get diagnoses. Two, if there's a psychiatrist involved. Three, if they've ever been hospitalized. It goes back about 7 years, similar to RX. You're going to pick up that information. If there's outpatient therapy that they're not admitting to otherwise, that gets picked up. We had one case where an individual admitted to anxiety. If you looked at the meds, you knew it was more than that. But when we got the claims data, it found out that the individual was actually treated with electroconvulsive therapy about 15 months prior to applying for life insurance. Now, there was nothing in the primary care records as it related to that. So we hadn't picked up claims data. Now, that's an outlier. You don't see that very often, but just to give you a degree. So the first thing I do is, what's the diagnosis? The second thing is I try to assess what the degree of that diagnosis is. And so you use things like we talked about, impact of life, into social, personal life, work. Have they been treated as an inpatient in the past? Is there a psychosis history? Has there been a suicide attempt or ideation? Underlying comorbid disease. I actually write that in most. I just say they don't have or they have. And so it just raises or it lowers the risk. And then lastly, the response to treatment. Not only have they been treated, what they've been treated with, but to the best of our ability, response to treatment. So I think you've seen these before, but I still get a kick out of them. So welcome to the psychiatric hotline. If you are an obsessive compulsive, please press 1 repeatedly. If you're codependent, please ask someone to press 2. If you have multiple personalities, please press 3, 4, 5, and 6. If you're paranoid, we know who you are and we know what you want. Just stay on the line while your call is traced. If you're schizophrenic, listen closely to that little voice, and that will tell you which number to press. If you're manic depressive, it doesn't matter which number you press, no one will answer. If you're anxious, just start pressing random numbers. If you're phobic, please don't press anything. If you're anal retentive, please hold. So Vincent van Gogh said, though I may be in the depths of misery, there is still calmness, pure harmony, and music inside me. I've always liked this. I've always wanted to feel that way, pure harmony and music inside me. What did Vincent van Gogh die of?
Suicide.
Suicide. Yeah, so that's, to me, it's the reality of mental health issues. I mean, this is a man, that had a tremendous gift, was aware of his struggles, still found, based on these words, calmness, harmony, and music, and still took his life as it related to his underlying mental health disorder. So I'll stop there. I really appreciate the engagement. You did a great job. And TJ, thank you. I know that's not easy to be feeding questions over. So thank you for doing that. Thanks for the great feedback on the questions. I wasn't sure we'd be able to do that, but you did a great job. So any final questions for me?
While I see any questions coming in, I just want to say thank you again, Dr. Greene. That was absolutely wonderful. And especially that last slide there, that was great. I love when you put the humor in there. I'm definitely more on the when impatient. I just want to talk to someone on the phone. So, but I think I have some OCD there. But also I wanted to say thank you to all the attendees so far here. This has been great. And I apologize if I didn't get all the questions through. We had over 175 comments and questions.
Wow.
So this was really, really interactive, but just work with us as we're getting the questions through. And if you have any other questions, like I said, I'm sure you can email Dr. Greene afterwards, or you can send questions to our info@us at optimumre.com as well. And we'll make sure we get any of those questions answered. But it doesn't look like there was any other questions, Dr. Greene. So thank you again. I think we'll still stick with that 10-minute break. So we'll probably come back here at 2. So if there's anything else, our panelists, do you want to say anything?
I just wanted to say thank you again to Dr. Greene. It was an excellent talk, and thank you to TJ, because I know he's not an underwriter and he did very well on his pronunciations of those medications and disease processes. And it's like, how do you say that? You did good.
And forgive me for going a little over. I apologize. And again, thanks everybody, and thank you, TJ. I know it wasn't easy.
Oh, it was great. I love it. Thank you, guys. We'll be right back in 10 minutes. So stay tuned if you want to go get a bio break or get some food. We'll be back shortly.